I have the pleasure of introducing Dr. Richard Bruns, who is an economist who specializes in cost-benefit analysis of public health policy. He is a senior scholar at the Johns Hopkins Center for Health Security, doing research and health policy work on pandemics and other global catastrophic biological risks. Dr. Bruns will discuss the staggering cost and economic cost of vaccine misinformation. Dr. Bruns, you have the floor. Thank you.
Thank you, Dr. Kavanaugh. Thank you, all of you, for having me here today. I'm going to keep it pretty informal because we've got a small group. So the paper that I'll be talking about, I just put the link in the slide so you can read along with it as we're talking. But basically, I will start by talking about the context of these numbers. What exactly do they mean? Like, people often throw around economic numbers, and it's helpful for you to understand where they're coming from, what the methodology is, and what we really mean when we're doing that kind of stuff. So as a bit of background, I used to work at the Food and Drug Administration doing regulatory impact analysis of government health policies. And this is, some of you might be familiar with program evaluation or those other kind of metrics. Some of you might be familiar with how the UK's National Health Service has a $1 per QALY threshold for medical care. And there's a lot of controversies about that, to be sure. So I'll try to briefly explain some of what we're talking about. Basically, the situation, whenever you are trying to figure out how to spend scarce resources, you want to ask, how am I going to do the most good with what I'm spending? Like, we live in a world where we don't have infinite resources. You have to choose where to spend things. So how can you know that you're actually doing something good rather than wasting resources on care that, could have saved a lot more lives if you're doing something else? We're living in a world where we're trying to figure out how to do the most good with our scarce health resources. And one good metric for that is how many lives you can save or how much disability you can avert for the amount of resources that you put in. But sometimes a benefit can have a complicated mixture of things. You're protecting lives, you're preventing people from getting illness, or you're also doing something like a poverty alleviation, making people earn more money, an intervention like a healthcare intervention that helps them get back to work. So how do you combine all of these various ways that you could improve someone's life into a single measure to know, okay, how can we do more good? So the way that we do that is by essentially monetizing the life and health gains, by converting the disability adjusted life years or quality adjusted life years, which is a measure of how many years of healthy life you can give someone with this intervention. And yeah, I know that it is possible to misuse the metric as you all are familiar with medical stuff. Any treatment can be useful in the right hands, but harmful in the wrong hands. With the right hands of how can we, give people as much health as we can, and that's where we get the monetization effect. And basically, the rule of thumb that we use for this is saving a statistically random person's life is valued at about $10 million. And that number comes from looking at what people do with their own life. It's not us doing a value judgment saying we think a life is worth this much money. It's looking at the economy and saying, if you taxed $10 million out of the economy, if you raise taxes, families have to have less money. What is going to happen as a result of you raising taxes? People are going to take more hazardous jobs. They live in more dangerous situations. They're not able to purchase better, healthier environments. So we can basically make the prediction that if you take $10 million out of the economy, you will statistically kill someone. That's kind of what the value of a statistical life actually means. If the government collects $10 million in taxes, that makes people poorer to such an extent that that poverty will probably kill someone. So if the government spends more than $10 million to save a life, they've actually killed more people than they've saved, because by taking out the taxes or the regulatory burden makes people so poor that the poverty will kill more people than the healthcare intervention that you're paying for. So that's how that number comes into place. It's basically essentially following the principle of first do no harm, You don't want to do more harm to people by taxing them into poverty or raising the cost of their medical premiums such that they drop out or can't afford other things. So that's where that $10 million value statistical life comes from. Like, we wish the number were higher. And as societies get more wealthy and more advanced, the number does go higher. Because conversely, you can imagine in an impoverished country in the global South, if you collect $10 million out of their economy through taxes, you're going to kill a lot more than 10 people. So in those countries, a government that spends $10 million to save a life is actually killing, they could be killing 10 people through the poverty of taxation than the life that they save. So as society gets richer and more developed, we have more money to spend, the value of the statistical life goes up. The number derived from that is basically $500,000 or 500,000 for the value of a life year, given some complicated assumptions about averaging and discounting, et cetera. But the basic numbers that you want to keep in mind are saving a statistically random person's life is worth $10 million, and extending 1 year of healthy life is worth $500,000. And that $500,000 is about 10 times the value that Britain's NHS uses on their cutoff. So they're basically not paying as much money as they should to save a life, but the system is very undercapitalized, et cetera. But the US government, when they're analyzing tax and regulation policies for the purposes of FDA or EPA passing a new rule, are we going to ban this pesticide? That's the $10 million cutoff. So the numbers that I'm going to present are, I am not going to claim that COVID misinformation causes this much economic damage. That's the dollar value that we're putting on all of the lives that are lost because of voluntary non-vaccination. Seeing the paper for the brief introduction, stuff that you already know about the harms of misinformation before we get into the numbers. And we're basically trying to be as transparent as possible with the data here. We're estimating, we did an analysis of all the different ways that misinformation can harm people. I'm sure you've heard a lot of stories. But we quickly found that when you're looking at the life years lost and the total harms, people not getting vaccinated was the main harm of misinformation and disinformation. Like, everything else is just a rounding error compared to people not getting vaccinated. I mean, vaccines are so good, they save so many lives. The main harm, like poisonings from other stuff, that's just irrelevant compared to not getting vaccinated, which is where the huge harm for misinformation is. So we start by looking, what is the total voluntary non-vaccination, by which we mean people who are not vaccinated. Obviously, people who are immunocompromised or have other medical conditions don't have a choice. They can't be vaccinated. But these are people who could be and choose not to get vaccinated. And we looked at the studies we could find on how many of that is due to misinformation. And you can see we've got a range uncertainty factor of 50 to 300 million. So top end of the range is 6 times the bottom range. And that's pretty standard when you're looking at these kind of unknown interventions. 2 brackets of our study, someone did an experimental kind of placebo-controlled interventional study where they exposed people to debunking the misinformation. They presented them with the truth. They helped clear out the misinformation, and that increased people's plans on getting vaccinated by like 4%. It's been a while, so I don't remember the exact numbers. So that's the lower end of our estimate. The higher end of the estimate is looking at how many people who chose not to get a COVID vaccine will normally get a flu vaccine. It seems reasonable that if someone normally gets a flu vaccine, they're probably not vaccine hesitant in general. Something about the difference between the COVID vaccine and the flu vaccine has them confused, and that's probably mostly attributable to mis or disinformation. And we figure if someone does not normally get vaccinated against the flu, that means even if they're not exposed to any misinformation, they probably also wouldn't get vaccinated against COVID either. They're probably non-vaccinated because of stressors, life issues, difficulties of getting to things, pre-existing beliefs that aren't due to misinformation, et cetera. So that's where the 2 numbers come from. We calculated, let's see, a certain number, and 5 to 30% of the harm of 5 and 30% is due to misinformation and disinformation. So again, at 50 and 300 million worth, that's mostly putting a dollar value on all of the harm, the deaths due to people who are dying from COVID and not getting vaccinated. So again, that 50 to 300 million number, it isn't saying the US gross domestic product goes down by 50 to 300 million because of COVID misinformation. It's basically you're killing 5 to 30 people each day. I think we used a value of VSL calculation, but you can roughly translate that into how many people is misinformation killing, multiply that by $10 million, and that's essentially where the harm number comes from. So whenever you're looking at these numbers, always try to keep in mind, is this a monetized number or is it just an economic number? Both analyses are out there kind of at the same time. So it's important to think about what exactly you're doing. And we actually did add a lot of things. We added medical costs, we added the lost productivity, we did add the actual economic harm, but the dollar valued economic harm is really only about 10% of that top line number. Again, most of the harm is it's killing people. And that's how you put that value on people being alive. I'll be glad to take questions or comments or anyone who wants a clarification.
I'm just curious, I'm fascinated from a prevention perspective. This can be used in so many different ways. And I'm curious if your agency or if you, Richard, have used this for prevention and in what way specifically? I mean, other than just the title. Go ahead. I'm sorry. Go ahead. Thank you.
That's a very good question. This kind of cost benefit analysis is specifically designed to make a budget case for people investing in prevention. Government programs are moving more and more towards you have to prove that this thing has value. So if there's a government program or even a private charity that says, we have a plan and we've done this trial and we have proven in a controlled trial that we can reduce misinformation by 10%, or we can increase vaccination by this amount of money, and they were asking for money to fund the program, we can basically say the value of that research now, because we know on standardized metrics that the government uses to analyze all of these policies and do budget things, we know how much harm misinformation and disinformation is doing. So that tells us, that makes a strong budget case for if you can reduce misinformation, and if you can reduce something, that's a lot of money or monetized value you could get from doing that. That gives the budget case. So if anyone is trying to get budget support either from a philanthropy, or the philanthropies are getting more and more results focused nowadays. So if you're trying to get philanthropic support or government support for a program that reduces mis or disinformation, you can point to these things and say, hey, this is the value. We're delivering good value for the money if we can actually reduce this problem. And that helps them compared to other things they could be spending their money on.
Yeah, thank you so much. Thank you for the really insightful talk today. To clarify my question, so there are public health groups that have been estimating the cost of pushing for pro precautions versus not precautions. And so I was wondering if you have had the chance to connect with those groups, or if you had any thoughts on that, because clearly, as you can see, a lot of public health agencies have not been supporting layers of precautions these days. And from what I've heard, there's been analyses on whether or not it's even worth the financial or other costs to do that and such. So wondered if you had thoughts.
It is often hard to budget justify something. And in general, people are trying to do an approach of how can you save the most life years with this amount of money? And it's hard to do the causality, but in general, like from what I've seen in the research, most public health interventions have a very good value for money. I think I've seen estimates like 10 to 1 or 20 to 1 benefit to cost ratio. Prevention really is very valuable. And I think more the difficulty is, can you prove causality? This kind of cost benefit analysis is kind of like a meta-analysis or a research synthesis. It has to rest on a foundation of, have you done research to prove a causal effect of what you're doing? Like if you have a prevention intervention, but you don't have any evidence that you're actually saving lives or saving health, or if you just have very large confidence intervals on that, any cost benefit analysis will have similarly large confidence intervals. But once you've proven causality, you've done a trial and say, hey, we did a test, this district implemented it, this otherwise observably identical district did not implement it, either because of random personnel assignments or budget cuts. If there's any kind of random natural experiment, one health district does this, we see an improvement in the numbers. Once you have that, it's usually very easy to argue for the value of that because you're seeing how many lives you can save for these preventative measures.
So I just wanted to comment, I'm in from the occupational health perspective, and when he's talking about precautions, for example, the hospitals are dropping pre-procedural testing for COVID for people coming into the hospital. That's an example that my mind went to immediately. So, Richard, is it too specific to try to use the information that you're putting out to something that concrete? In other words, prevention methods are being dropped with pre-procedural testing, with masking, all of these COVID precautions that affect the public health and the greater public health in the hospital setting. And then also just walking into certain areas where there is a higher incidence of COVID, for example, or for someone who is at greater risk for COVID. So I'm just trying to make this real.
Yes, thank you. That concrete example is very good. So short answer, it relates very closely to the overall use of cost benefit analysis.
Right.
Hospitals, like one of the projects that I'm working on at the center is improved personal protective equipment. And it amazes me how hospitals are just unwilling to pay for higher quality PPEs. Like there's been improvements, like you can basically for about $1,500 buy a convenient PAPR helmet, like welders use them. Like a random redneck welding shop is just accustomed culturally to paying $1,500 for every employer getting a powered air purified respirator as part of their job, and it's just, you know, standard equipment. But hospitals won't do that, and I know they're kind of hard to use, but it seems to me that they should care a lot more about better protective equipment. And my mom's a home health nurse. I think we have the capacity to basically give every first responder their own PAPR and training how to use it to keep in your emergency box for when things get bad. And when you think about the cost of disruption to care, like obviously you have like nurses and doctors, their lives are also valued in the VSL. We try to be fair and do it for everybody. But you also have like the cost of healthcare disruption when somebody gets sick. Hospitals should be issuing a PAPR to everyone. That would clearly be justified on cost benefit grounds, but you just can't get them to run the numbers or think about causality. So anything that you can do to get people to think about, like Dr. Wang said, the proper full consequences of stuff, try to get better decision making. It's hard to talk to the right person, but sometimes you can convince them. As relating to misinformation, if you can demonstrate that misinformation was the cause of people dropping a very valuable safeguard, you would first have to say, okay, what is the value of this safeguard? And, the safeguard that we're doing, it saves the doctor's lives, prevents transmission, et cetera. So you might come up with a number. I'm just pulling something out here. Like this precaution, this safeguard has a positive value of $100 per test. And again, I don't know what that is for sure, but suppose that you did the numbers and found like this preventative measure has benefits of $100 more than the costs. If misinformation caused people to drop that safeguard, then that would be a cost of misinformation. If anybody, you might do a survey of like, why did you choose not to do this? Like maybe, half of them would cite, administrative stuff or like random normal crap that you get in hospitals all the time, even when there's no misinformation. But if 20% of the time you find that the decision maker said, well, I did this because, they believe some kind of misinformation, well, then it's that 20% of the harm of dropping this valuable procedure can then be attributed to misinformation.
Well, what about a policy that stopped requiring use of masks or respirators? Could it be possible to do an analysis of that where not so much misinformation, but actual policy as you're withdrawing your recommendations and making them more lenient, and that has an impact on increasing disease? It would also, I assume, be possible to figure out the economic impact and societal impact of that.
Yes, most of my projects in the last couple of years have been about indoor air quality. The short answer is we've actually found that proper HVAC systems, better ventilation, better filtration in a lot of real world scenarios are basically almost as good as masking. You can get the same kind of benefits for like slightly less political harm or less drama. I mean, obviously, if a mask is worn properly and effectively with proper fit testing, it's much more cost effective than an air filter. But especially in the situation of schools, I wasn't sure from your question if you're talking about requiring doctors and nurses to use them or the general population. But of course, the numbers are slightly different. With the general population, with actual, compliance, might not be having good masks. The engineering controls, I don't know if there's any occupational or industrial hygienists around here who are familiar with the hierarchy of controls, where engineering controls are generally considered superior to PPE in mitigating a hazard. It is, especially in healthcare settings, there is a substantial benefit to these mask requirements. And yeah, you can definitely calculate the harms of both not doing masks or not doing the proper HVAC system. I would encourage everyone to demand good air filtration, demand MERV 13 or better filters in all of your workplaces. Make sure that things are properly ventilated. Research these things called Corsi-Rosenthal boxes that are actually better than the commercial air purifiers in some cases. So definitely really focus on your indoor air quality. That's super important for anyone, especially in crowded environments. And there's huge, huge benefits to that. And in a world of misinformation, we hope that it's going to be a lot easier to get everybody on board with indoor air quality than some kind of mandate on individual behavior. But yeah, if you're in a place where a mask mandate is on the table, you can come in and say, yeah, these are the benefits. Masking is really huge. PPE is really huge. And somebody who spreads misinformation about that takes away this good thing from us.
Dr. Bruns, thank you very much for.
Thank you. Had fun being here again. Feel free to email me and enjoyed chatting with y'all.